We'll kick off. You're very welcome. Thanks very much to everybody for coming along to the latest in our Irish Cancer Society Decoding Cancer events. My name is Robert O'Connor and I have the pleasure and honour of being the Head of Research for the Irish Cancer Society. Decoding Cancer, I see a few familiar faces, a few people that I've seen even less than a week ago from our last event, looking at some folks in the back there. But for those who aren't aware, Decoding Cancer is part of a communication series that we run in the Irish Cancer Society focused on research, and we try and bring in new and exciting angles and aspects, get experts in to talk about different parts of cancer. We try and promote Irish cancer research. The Cancer Society, through the donations that we get from the members of the public, supports the research and work of 120 researchers all around the country, and we like to showcase that. We like people to see what's going on in that area and understand some of the things and maybe get some of the hope from some of the new developments that are coming along. I'm very grateful to our host this evening, Trinity College, for giving us this fine facility, and they've been very supportive of all of our activities in this, and also to our, my colleagues in the research department who helped bring this about. So we're here this evening to speak about bridging the gap, and I suppose when people think of cancer, the first thing that often comes to mind is to think of the cancer cells, and we were having a conversation about that a moment ago. And indeed, cancer cells and the tumour are an important aspect, and we want to be able to overcome that aspect. But I think as research has led to improvements in outcome, we've recognised that there's a whole other aspect to cancer. There's the person that carries the cancer. There's the community and people around that person that are impacted by that person having a fear of cancer, being diagnosed with cancer, going through the barrage of treatment and all of the consequences and sequelae that that can have, and that there's a lot of benefit to looking at that more holistic aspect of cancer in terms of how we might improve things. So we've got two great speakers here this evening. Dr. Kelly Irwin joining us from Harvard, from Boston, and Dr. Paul Dalton, who's joining us all the way from the south side of St. Vincent's Hospital. I'll give a little background on them, but I'm very, very grateful to them. And I suppose this also works out well. Yesterday was World Mental Health Day. Many of you may have been aware of that, and I think it's good to have a tie-up and see what we know, what we don't know, and where things might potentially be going. So a little bit about our two speakers, and if everybody's okay, what we'll do is we'll get Dr. Irwin to speak first. She's a little video as well to talk. And then Dr. Dalton is going to come on and I guess narrow that down a little bit to the Irish kind of context as well. And then both have agreed to take questions and comments and maybe have a little bit of interaction with the audience, if that's okay. So a little bit about our speakers, and we really are very pleased to be able to attract some of the calibre of our two speakers this evening. Dr. Irwin is an instructor in psychiatry at the Harvard Medical School and a faculty psychiatrist at the Massachusetts General Hospital Cancer Center and specifically the schizophrenia program. She's been very involved, I suppose, in the collaborative care and community engagement program within there. She comes very highly recommended to us. She has been to Ireland before, so we knew we'd a good quality speaker coming. You spoke at the IPOS meeting. Was that last year now? This all kind of merged into one. But that was a very important, if not even a milestone in Ireland, because I guess it's helped springboard the recognition of needs for support in this area. And those needs are now articulated in our National Cancer Strategy, which was published back in July, which I think Paul will mention as well. Dr. Irwin investigates people with severe mental illness, including schizophrenia and bipolar disorder, and I suppose her talk will focus a bit about the interplay of cancer, the risks, and that there. Our second speaker is Dr. Paul Dalton, who's a clinical psychologist at St. Vincent's Hospital, and he's also got a joint academic appointment in UCD. And as I said, he's going to bring things along and I suppose integrate a little bit with our National Cancer Strategy. So enough waffle from me. We need to focus on our speakers and give them the forum. So I'd like to invite Dr. Kelly Irwin up to give your talk. And thanks very much again, Kelly.
Very much. It's really an honor to be back in Ireland. We're going to start with a video, actually, which will bring a bit of humanity and human face to this issue of bridging the gap.
It does exist. and we all can be successful in life, despite the stigma that's out there.
My dream is that one day the stigma will be totally erased.
Depression or anxiety, that's like life. Doesn't mean you have a bad brain, right?
Mental illness does not discriminate. We are not scary people.
We're just like you.
You're not alone. There's always help available.
You don't need to go through this by yourself.
We have the greatest hospital in the greatest
Outside of
city,
Ireland, of course.
in the greatest country, at the richest time in the history of the world. And yet, sitting across from us, you have a population that lives so fewer years than the non-mentally ill. We do such a bad job for people with severe mental illness in this country that the survival rate is 30 years less. 30 years less than for people without severe mental illness. And they're right in front of us, and we're walking past these people every day. When you think about that, you feel like, all right, we got to do something about that.
I heard about him first from colleagues. You know, we're worried about this person, he won't go see psychiatry, he got hospitalized repeatedly, medically and psychiatrically. And they're kind of like, but you see him? And I will tell you the truth, that I thought this would be a challenging case.
Jonathan was having chemotherapy as an outpatient, and we were just sitting there in the room, and all of a sudden, this very nice person came along.
Here he was at home in pain, suffering, confused, and paranoid. Why would he come to an additional doctor's appointment that he didn't think he needed? So instead I went down to infusion.
I told him that I had a good feeling about her, and I said, let's give her a chance.
Said, I don't need you, but I did come back next week. And then the week after that, and then eventually he did come up to my office to see me. But Jonathan inspired creating a whole dedicated program.
Jonathan was lucky because his mom and dad loved him and advocated for him at every step. And he was lucky that he met Kelly. What we need to do is not make it about luck anymore. That we've set up this system that can be replicated in New York, or Detroit, or LA, or in the middle of Iowa. But it's a system that people say, we need to have in our place, because when somebody with severe mental illness comes in the door, that's the right thing to do for them.
Jonathan and his family really showed me how important it was to do things differently, and how much we could do as a community at MGH if we worked together and didn't start with like, well, that's not my job. You know, and started instead with, this is what this person needs and his family needs, and let's try it.
She was able to help him with medications so that his mind was clear to the very end. He could talk to us and we could understand him. He could say goodbye to all of us.
You know, the thing that sticks with me, as a parent, his mom said to me, finally, I could stop being his caregiver and be his mom.
When I have a young person like Kelly come to me and say, hey Dave, I have an idea. I'm too old to come up with ideas on my own, but I know a good one when I see one. We thought it was going to take her 18 months to enroll in this particular study, and she had filled the enrollment in 3 months. The outpouring of support from the cancer community, the medical oncologists, the surgeons, the radiation oncologists, we called Kelly and said, hey, I have a patient for you. When people want to do the right thing, they want to help, they want to change the way we take care of people with mental illness. We just needed somebody like Kelly to bring everybody together and make it happen.
I think it's rough for anybody, and to be able to see Dr. Irwin, it just enabled me to be the strongest I could be mentally to get through the experience. Because if I had ended up having to have hospitalization in the middle of a cancer treatment, you know, that would not have been good.
That's right. You've been through a heck of a lot.
It's all about meeting an individual patient where they're at in their illness. And it's doing it for a population that is the most underserved in our society.
Also, I remember, understandably, that the idea of surgery was scary.
Yeah.
And that was something that did keep you up at night.
I had an incident that happened to me when I was a little stuck in a snow cave. And I couldn't get out. I was there for a long time. I don't know how long I was there. And panic set in. Loss of control, you're trapped. And so
but I remember though, it was like you gave me an infusion, and I remember you told me that story about the snow cave. And I'm not sure that everybody would have made the same connections to that story and how that related to your life.
Yes.
So we're really
We wouldn't ask somebody who was paraplegic to walk up a flight of stairs. Why are we asking somebody with severe mental illness to show up at 8:30 in the morning every Tuesday on the button for a 20-minute appointment?
Your team called me and said, I don't know what we're going to do. We're not going to do this. You did yell a fair amount. There was some yelling. That piece is really rewarding to see kind of when people would realize, like, hey, that worked. We could do this again. I think that's really happened. The culture has changed. And there are people who really just didn't think about mental illness before.
For Kelly to do this and make these patients see, again, it brings the chasm between the mental health community and the medicine community, the oncologic community together. And it takes care of somebody who is really otherwise powerless in our culture.
People ask you, how do you work with cancer patients? That's enough. But how do you work with cancer patients with schizophrenia or bipolar disorder? There's so much suffering. And I really feel that I was meant to do this work. I have 3 little girls, and I would never leave the house if I wasn't leaving to do something meaningful.
We're moving the bar and we're doing the right thing. And when we're done and it's time for us to retire, we can at least look back and say, well, we didn't ignore something that was right in front of our face. One day, we'll look back and we will see that this trial was the beginning of the end of that 30-year past.
Thank you very much. So for me, it always helps to hold those stories in mind as we listen to the data and try to think about how to bridge the gap between cancer and mental health. Because I do think that often brain illness is invisible, and we don't always have the language to talk about it. We know that 1 in 3 people will be affected by cancer, but 1 in 5 of us will also be affected by mental health concerns. And yet we are reticent to talk about that together as a community. So we're going to present a few myths to start. Number 1, mental illness is uncommon, right? I just shattered that one for you, right? Number 2, people affected by mental illness die primarily from suicide and violence. Number 3, people with mental illness cannot participate in clinical trials. So during the talk, I will present data that I hope will show you that none of these myths are grounded in reality. So number 1, mental illness is very, very common. And unfortunately, 90% of schizophrenia worldwide is untreated. And these are underestimates. We talk about 13 million people in the United States, 1 in 5 people affected by mental illness, mental health concerns more broadly. It's really quite shocking if you haven't quite thought about it like that. And also our current health system just doesn't work well for people who have mental health concerns, and particularly people who have both mental health concerns and cancer. They end up in the emergency room in the hospital like Jonathan did, and they end up costing our health system more. And we can do things differently and better. So if there's 1 or 2 takeaways from my talk tonight, I would like you to leave the room knowing that currently people with serious mental illness die 30 years earlier than the general population. Meaning in Massachusetts, where I'm from, people with schizophrenia die at 52, whereas people without mental health concerns die at 82. That is shocking. It's a human rights violation. And the number 1 cause of death for people with serious mental illness is heart disease. And the number 2 cause of death is cancer, just like all of us. So that mortality gap isn't explained by suicide or violence. Now to cancer, what we're here to talk about tonight. Although individuals with serious mental illness are equally likely to get cancer, they are significantly more likely to die from cancer. 2 to 4 times more likely to die from breast cancer, colorectal cancer, head and neck cancer, lung cancer, really any cancer we've done the study on. What's going on? Why is that happening? Well, as we heard, from Robert as he started us off, it's been wonderful. We had amazing advances in cancer treatment. We can see there, we have multimodality treatment, we have clinical trials, and now women who are diagnosed with breast cancer, from 75% surviving in 1975, now nearly 90% are surviving, which is good news, but unfortunately not all groups are benefiting equally from those advances. We know that there are racial disparities, disparities based on socioeconomic status, and amongst the most vulnerable patients are patients with serious mental illness, who are, as you see there, nearly 3 times more likely to die from breast cancer compared to the general population. I think an important thing to remember here, because sometimes when we can hear mortality disparities, we feel overwhelmed, like I can't do anything about that. That's because of a lot of things out there that are unmodifiable, because of poverty, because of homelessness. And I don't mean to say that those factors don't matter. But what I do mean to say is that a significant portion of these disparities are due to inequities in treatment. People are not getting equal screening, they are diagnosed later, and even when they hit the cancer center, they're less likely to get recommended surgery, radiation, chemotherapy. And that's something that we can do something about. Furthermore, they're less likely to be referred to clinical trials, and they have less access to palliative care services. So what's driving that? Well, what we've learned is that people who have access to mental health services at the time of cancer diagnosis are significantly more likely to get that equitable cancer care. So for example, 1 in 2 women with schizophrenia who are treated at the academic cancer center where I work, we learned were having disruptions in their cancer care. But people who were linked to a psychiatrist or who were on antipsychotic medication did 10 times better. And that's modifiable. That's something that integration of early mental health care can change. So I hope we feel that that's hopeful. I always like to have a solution. I don't want to throw out scary facts without giving you a solution, or at least the beginning to one. So if we think about the patient and clinician and self-care systems-based factors that contribute to this inequity, I think that's important. It's not all about health behaviors. Yes, people with serious mental illness are more likely to smoke. But no, that does not explain the mortality disparity. Our training as clinicians is quite segregated. Oncologists aren't trained in mental health care, and most community mental health clinicians aren't trained in cancer. And our current healthcare system is quite fragmented. And as we started today, there's a lot of stigma about mental illness, and that impacts the continuum of cancer care, which you see there, from prevention through end-of-life care. And downstream, that leads to poor quality of life and decreased cancer survival. So here's Jonathan and his mom, Joan, who you heard from in the video. He was 42 when he was diagnosed with rectal cancer. And really his case was reflective of the fragmentation of healthcare and the need for better integration. As his cancer progressed, he was in more pain, he needed more invasive procedures, his psychiatric illness got much more out of control. He was agitated, he needed to be restrained, he was in and out of the hospital repeatedly and suffering until we went to him and delivered a patient and family-centered intervention. And then as he got more clear-headed, we were able to differentiate his mental illness from his wishes. We were able to hear that when he said, I want to focus on relief of suffering, and know that that wasn't his mental illness talking. And therefore, we were as a team able to focus on palliative care and enable him and his family to have a peaceful death, which is something certainly that they hold on to going forward, and something that everybody deserves. And the truth is, when things are overwhelming and seem too hard or have too many steps or barriers, we do them less. In other words, sometimes we feel helpless. And as a medical oncologist said, there's a groan that's uttered when you're taking care of a patient with schizophrenia. And I imagine that that lack of enthusiasm translates into poorer care. That is not because of poor intentions or not wanting to try hard. Oncologists are amongst the most giving, caring people I know, but they don't have the tools and they don't have the time. The healthcare system isn't designed to effectively care for patients like this. And so these quotes come from qualitative research that we did with oncology and mental health clinicians. And I think they illustrate some of these factors that I'm talking about that we can address in interventions. So in terms of patient factors, if people have uncontrolled psychiatric symptoms, yes, they fall off the grid. They get ill when they stop taking their medications. But also, what happens when someone gets chemotherapy and they have physical symptoms and then they go home to no one? They don't have a spouse or a roommate or anybody to help take care of them. And maybe it's more challenging for them to remember their medication doses. That person isn't going to do as well. And for us as clinicians, I think it is important to remember that there's a need for training. It's very easy for an oncologist to feel overwhelmed. We're not trained to talk about cancer with schizophrenia front and center. And mental health clinicians also get very overwhelmed when they hear the word cancer or hear the word palliative care. And finally, the system. And this is something that the National Cancer Strategy can change. You know, that there's not enough access to psychiatry. It's not okay to wait 6 weeks to see someone or 3 months to see someone. With cancer treatment, we cannot wait. So if you Google Cancer Center and you Google mental health clinic, this is what you see. I love this slide because I think it really conveys a lot of the stigma and fragmentation that's present in our current health system. Look at the differential level of investment and the message that sends to the people walking into those two buildings. Beyond that, think about the fact that there are different clinicians working in those systems, different patients. There's usually not a shared medical record. And care becomes quite fragmented for the patients who most need us to be communicating effectively. And finally, in terms of thinking about this disparity, it was shocking to me when I realized that 50% of clinical trials exclude people with mental illness. There was no scientific rationale for that. That is based on stigma and the perception that people with serious mental illness cannot complete clinical trials. That's something that I hope to challenge in this talk. So collaborative care is a really effective evidence-based approach that integrates behavioral health care into primary care. There's a strong evidence base for decreasing depression symptoms and also for improving medical outcomes in the context of primary care. But who's been excluded from these studies? People with serious mental illness and people with specialty medical concerns like cancer. That's that top right quadrant. People who have both serious mental illness and cancer. And how do we design a model of care that meets their needs? So this is the model that we've developed and tested in a pilot study. Traditionally, at the time of cancer diagnosis, you'd have an oncologist and a patient. But for people who have mental health concerns, I'm arguing we need to do things differently. For almost everybody, this is also critically important to bring in their caregiver at the time of cancer diagnosis, someone else who can listen and hear the plan. But additionally, it's important to bring in a mental health professional, in this case a psychiatrist, so that the psychiatrist and oncologist can collaborate to design an integrated treatment plan. And additionally, we bring in a navigator, a social worker, a case manager, it could be a community nurse, who addresses barriers to care, such as the social determinants of health, for example, securing transportation, and also establishes communication between community-based clinicians and the cancer center. And with the person and caregiver at the center, hopefully this model can enable people to have improved cancer outcomes. This is the model we tested in a pilot study last year. We included people with serious mental illness, as you can see there, schizophrenia, bipolar disorder, major depression, who had recently been diagnosed with GI, breast, lung, or head and neck cancer. And they received a 12-week intervention consistent with the model of care that I just showed you. We tracked their psychiatric symptoms and their receipt of cancer treatment, and we did exit interviews with patients and caregivers and oncologists. What did we find? So as you can see, the main objective of this study was to see, is this feasible? Is it possible to do a study in this population, and is it acceptable to key stakeholders? We learned that there was a significant unmet need, and we were able to recruit people rapidly to this trial. We did that by modifying trial procedures. We used a verbal process of consent where we explained things clearly and understandably to people, and we met them where they were, in the hospital, in the community, in the clinic, and rapidly accrued to our trial. 88% of the people we approached or their guardians consented to the study, and 88% completed all study assessments. This is strong data on the feasibility of this model, and strong data on doing a clinical trial in people who have both cancer and serious mental illness. Was the intervention acceptable? Did people find it helpful? Yes. Patients, caregivers, and oncology clinicians found that the intervention was useful and positively impacted cancer care. 6 of the 30 people who enrolled in this trial had not received recommended cancer treatment or had significant delays ranging from 1 to 15 months before they enrolled in the trial. All 6 received some recommended cancer treatment that they wouldn't have gotten, and 5 of 6 received everything that their oncologist recommended during the trial. I think sometimes it's helpful to hear things in stakeholders' own words. It helps me to really understand the impact of the intervention, and that's why we did qualitative interviews with stakeholders. So these are patients' words, what mattered to them: establishing trust, learning I was not alone, managing their mental health symptoms. I'm always thinking, and sometimes meeting with the team helps me think in the right direction. Helping with resources. She got me into rehab, taking the burden of care off my daughter's shoulders, and then coordinating care. Everybody got together to help me. It took a whole village of doctors to get me through this. This is the gentleman in the video who talked about being angry. He had experienced a stroke. He had become homeless, and he was in a rehab setting where he knew no one. How he retained any hope, I have no words to explain his resilience, but he also became extremely anxious and scared of the radiation mask. We were able to address his anxiety and get him through radiation. He's doing well. He's actually teaching other patients at the rehab to encourage them through their cancer care, and having that sense of purpose has been really helpful for his quality of life. What about caregivers? Now remember, caregivers for people with serious mental illness are very different. Most people are not married. Only 14% of people live with spouses in our trial. Who was caring for this population? Sometimes it's other family members, parents, siblings, adult children, and sometimes it's community mental health clinicians who may be on the front lines and may be the only people who are in these patients' lives. And they are actually experiencing significant burden, and we're very appreciative of the intervention. If you got a team approach for the whole person, this patient became more trusting and more open to medical care. This is the person who had avoided medical care for more than 10 years, who we brought into the hospital on an emergency basis. We also promoted the integration of psychiatric care during acute cancer. Mental health piece gets lost. Having a connection during acute illness was very helpful. We engaged caregivers in the process. Sometimes a caregiver is more able to explain things in language that makes sense to people than I am, for example. What was really helpful was the group meeting. My sister didn't want to do treatment at first, but when I explained it in plain English, she got it. And then additionally, we helped to bridge the fragmented healthcare system. The doctor came from oncology and understood schizophrenia and could tell us what to expect. I've never had a provider with both perspectives. What about oncologists? They greatly valued the proactive, flexible approach and the fact that we were available for consultation throughout the duration of cancer care. So as this oncologist says, being involved throughout treatment was invaluable. They knew when my patient was hospitalized, and they reached out to me. In a dream world, I could call psychiatry and go see patients together. It also changed oncologists' willingness to recommend stage-appropriate cancer treatment. As this oncologist states, it enabled me to feel more confident we could actually accomplish something. When oncologists are scared of doing harm, when they're scared that a patient won't come back to the clinic, they're less likely to recommend surgery or chemotherapy. How can we change that? By knowing they can page me, by knowing that they have a team to support them. And finally, they stated that the intervention made a critical difference in the person receiving cancer treatment. She would not have received care otherwise. They managed his acute anxiety, and that allowed him to complete treatment.